I'm joined now by Professor Filippo de Marinis here at the Multidisciplinary Thoracic Oncology Conference in Lugano. Filippo, you're talking about a concept, not just one treatment, but the concept of maintenance treatment. There's a big debate whether or not you should use maintenance treatment on patients. But first of all, in the context of non-small cell lung cancer, what constitutes maintenance? What is maintenance?
Many thanks for this question, because it's very interesting and is useful for clinical practice. So up to now, the standard treatment of first line of advanced non-small cell lung cancers were represented by an induction chemo realized with 4 cycles for patients with stable disease, or 6 cycles ex maximum for patients responders, and then some wait and white time because for the toxicity of the chemo and for the negative results obtained to prolong the time of the first line realized with chemo, especially with a doublet platinum-based with a 3rd generation drug. So this is the historical approach and the standard approach for 6 cycles at the beginning, and then stop for patients responders, for patients stable.
And then, of course, the question is, what do you then do?
Yes. So maintenance is a new paradigm where it's possible to prolong the treatment, or with chemo, or with new biological molecules, target therapies, to prolong treatment without, in absence of toxicity, until or for a fixed number of cycles, or until progression disease.
So could you take me through the scheme of things? You begin with a patient, you have a diagnosis, you then prescribe primary therapy, first-line therapy, you then get to the end of that therapy. Now, how do you take the patient through that? Begin with a typical patient.
We have different options considering the first-line treatment. So, if I realize an induction chemo with a doublet platinum-based for 4 or 6 cycles, and I want to apply the maintenance strategy, I have 2 possibilities. Or I continue one of the drug used in the induction therapy, or I use another drug. And this another drug can be a chemo or molecular or biological molecular.
And at that point,
yes, but we have also another options, because if as induction I used a chemo plus bevacizumab, very useful in US, or cetuximab, not yet approved in Europe, the maintenance treatment is represented the continuation of the bevacizumab or the cetuximab. So this is a maintenance continuation of one of the drug biological used in the first approach, because the first approach can be represented by chemo alone, the most part of the regimen used in the Europe, or chemo plus bevacizumab, very useful in US.
So initially then you can go with the biologic, you can continue that, and that's there are data to show that that has some benefits in consolidation or in maintenance. But how does the status of the patient with respect to response affect your decision making and which choice of agent at that point when you've finished the initial therapy?
Patients, we have some difference among the large population of patients, because we have in clinical practice some patients that want to have other possibilities, especially after our initial response, because in the mind of the patients, if I am fighting with the cancer and at the end of the induction therapy I obtained a response, is very crazy to stop all therapy because the response was good. The mind of patients is okay, after this initial advantage, continue.
And the mind of the doctor?
Yes, and ask to the doctor to have other possibility to continue immediately the therapy, not waiting for the second line opportunity for the metastasis. So maintenance is a concept that is good for clinician, but is good maximum for patients.
And a patient who has stable disease is in a similar category?
Yes, because a stable disease is a historical problem. Stable disease is not an advantage, it is not a progression. What is stable disease? The prognostic role of stable disease, what is? We don't know, because stable disease can represent in the same time no response. And no response is a negative result. So stable disease is positive or negative result? This is the question at the debate. But for this particular group of patients, I think that give you an opportunity to prolong a treatment without toxicity, if no toxicity is present, trying to obtain yet another some response and advantage is now is a great opportunity for this kind of patients.
And the patients who do not achieve a response and are not maintained with stable disease, but their disease continues to progress, how do they view further therapy?
Second line, because this is a negative group of patients that can receive immediately another treatment, named the second line treatment. The problem is not for these 25% that at the end of induction therapy is evaluated as progressed, but the problem is concern the other 75% or the responder patients of this big number of patients evaluated as stable disease.
So the question, maintenance treatment, yes or no, what is the answer emerging here from Lugano?
From Lugano is emerging new opportunities and new data. Up to now, we have two trials, very important. One realized with pemetrexed in a switch maintenance study, where pemetrexed given immediately after an induction of different chemo realized a very impressive PFS advantage. Another opportunity is given by using erlotinib after chemo as emerged from the Saturn study, and erlotinib offered for stable disease patients a new opportunity. But not from Lugano, but from the next ASCO meeting in Chicago, we'll find the results coming from the Paramount study, where pemetrexed is given immediately after the end of cisplatin, and pemetrexed given as a first line. So the real maintenance, I start with the cisplatin and pemetrexed, and I continue with pemetrexed. I participated to this study. We send the abstract to ASCO, so I think that it could be a new, very great, important opportunity for patients.
And briefly, the doctors should be learning from all of this. What sort of practical message?
Practical message is consider the opportunity to continue treatment, but avoiding toxicity. And for patients that want to have more results, but considering the patients, not considering the tumor.
And biologics float to the top of these therapy options.
Yes, biologic is an opportunity. I think that up to now we have no very big results, with the exception of erlotinib. We have only the bevacizumab results, but the future is represented by target therapies.
Filippo, thank you very much for joining us here on eCancer TV.
It's my pleasure.